Could you just go through the actual symptoms that the patient would be complaining of?
Well, functional GI disorders in general are abnormalities of gut function. It could be diarrhea, constipation, nausea, vomiting, abdominal discomfort. And then we partition that into specific syndromes like IBS or functional dyspepsia and the like.
Would it be standard routine to go through physical tests to exclude any other reason, for argument's sake, if there's a tumour or if there's an ulcer, or is that now thought not to be worthwhile putting the patient through that?
It's really two parts. What you're doing is you're looking at the symptom profile, and you're seeing if it meets certain patterns. Irritable bowel, for example, is abdominal pain associated with change in bowel habit. It could be diarrhea or constipation with bloating. Once you hear that, you say to yourself, well, there are other things we need to exclude. Is this inflammatory bowel disease, ulcerative colitis, or Crohn's disease? Is it celiac disease? So once you have the symptom criteria, what you're really doing next is you're trying to do a minimal amount of studies to exclude other disease. I think the risk in our society is over-treating, is really doing over-diagnosing, really doing too many studies, when if you have a positive diagnosis and a minimal number of studies, you're okay.
In other words, you can make the diagnosis mainly from the history.
Very much so. Most expert, good clinicians know when someone has IBS, but you do need to do some studies to exclude the other possibilities in a smaller percentage.
Are there any specific risk factors that patients presenting with these symptoms that you could say, well, you're more likely to get it or you're less likely to?
Yeah, I think there are certain basic differences. We know that women are more likely to get functional GI disorders than men. About 60% of people with functional GI disorders are women. There are differences in healthcare seeking. Women are more likely to go to the doctor, so in the clinic it could be as much as 80%. Another risk factor that's very important is the presence of early infection. If you have a prior infection, we often call that post-infection IBS or post-infectious IBS, because the infection, and these days the whole idea of the microbiome, which we may get into, the bacterial flora of the gut, can play a role in altering gut function. And then, of course, you can have dysregulation of the brain-gut communication, where early trauma, sexual and physical abuse, psychiatric comorbidities like anxiety and depression can worsen these symptoms.
Are there any dietary factors that could be significant?
Well, these days we're starting to look at the role of food and diet. I think in terms of the treatment end, we're looking at certain substances that might not be absorbed and digested as easily, and they stay in the gut, and the bacteria kind of chew it up and produce gas. We talk about that as FODMAPs, high FODMAPs, fermentable oligosaccharides, monosaccharides, disaccharides, gluten. These are substances that can lead to an increase in symptoms. It's not a risk factor for development of IBS as much as it's a factor that leads to flare-ups or worsening symptoms of IBS.
Yeah. We hear a lot about the Western diet, obviously contributing to an increase in diabetes and heart disease and obesity in general. Is there any connection between obesity and the increase in, say, sugar with bowel symptoms?
Not to any great degree. We actually did do a study where we put people on a low carbohydrate diet, actually the Atkins diet, and found improvement of symptoms. So there is to some degree, but there's a lot of individual variation.